Upper gastrointestinal bleeding is defined as a bleeding from gastrointestinal tract proximal to the ligament of Treitz, or saying simple, a bleeding from the esophagus, stomach, or duodenum. Upper gastrointestinal bleeding can present by different ways. Massive, active bleeding most often presents as hematemesis, vomiting of blood. On the other side, coffee ground vomitus, vomiting of black material that is assumed to be blood, usually implies that bleeding has ceased or has been relatively modest. Melena, passage of black, tarry stools, is regarded as a typical sign of severe upper GI bleeding. However, it can be occasionally caused by bleeding from small bowel or right colon. In contrast with this, hematochezia, that means passage of fresh or altered blood per rectum, is typical for lower gastrointestinal bleeding. However, it can be occasionally also the consequence of very massive, usually ongoing upper gastrointestinal hemorrhage. Finally, positive test for blood in stools without visible blood, defined as occult bleeding, may be the only marker of bleeding from any part of gastrointestinal tract. When isolated, it usually implies on low intensity of hemorrhage. We should be aware that presentation of blood or blood-colored material in vomitus or stool doesn't necessarily mean bleeding from gastrointestinal tract. It can be consequence of swallowed blood, for example, from bleeding nipple in breastfed infants, or from upper or lower respiratory tract. Moreover, not everything looking like blood is blood. For example, vomiting of red or black juice or food such as beetroot, blackberry may sometimes very closely resemble vomiting of blood. Be aware that patients with severe upper GI bleeding can be hemodynamically compromised or can even present with symptoms of hypovolemic shock, such as tachycardia, tachypnoea, hypotension, changed state of consciousness, cool slimy skin, and low urine output. In such cases, we must initiate appropriate restitution before endoscopic diagnosis and therapy. Upper GI bleeding is an emergency, so we must assess a patient and appropriately manage an airway, breathing, and circulation if necessary. Then the patient should be admitted to the hospital with organized GI endoscopy unit which is competent in therapeutic endoscopies. Severe bleeding need urgent endoscopy and treatment within a few hours. However, modest bleeding need endoscopic diagnosis and treatment within 24 hours. The effectivity of pre-endoscopy intravenous PPIs is controversial. However, it has been shown that maintaining gastric pH above 6 optimizes platelet aggregation and clot formation. And high-dose PPI therapy results in resolution of bleeding and reduction of need for endoscopic therapy in many patients. Before starting endoscopy, a patient needs pre-endoscopy evaluation. First, we must check for vital signs and monitor them. If needed, resuscitation with crystalloid or colloid solution should be applied. A history should be taken and laboratory tests performed, especially for hemoglobin and platelet concentration and coagulation tests. If necessary, transfusion should be applied. There are some controversial pre-endoscopy actions, such as nasogastric tube placement and aspiration of blood from the stomach. It can be of diagnostic value since presence of fresh blood is a sign of high-risk lesion, but it has low sensitivity and specificity. and also therapeutic value, reduction of quantity of blood and therefore better visibility during endoscopy. Use of prokinetic agents such as erythromycin or metoclopramide before endoscopy is also controversial. Their function is to reduce the quantity of blood and therefore assure better visibility during endoscopy. What is the diagnostic yield of upper endoscopy? The first, recognition of bleeding lesion with making decision about endoscopic therapy. However, in 10 to 40%, the origin of bleeding is not found. And the second reason, recognition of the cause of bleeding. For example, infection with Helicobacter pylori. There can be many reasons causing non-varicose upper GI bleeding. However, the most common causes are ulcers, especially stress and ischemic ulcers in young children and infants, and peptic ulcers or erosive gastritis in older children and adolescents. Reflux esophagitis is a common cause of bleeding in all age groups, as well as Mallory by Steer. However, there are many rare causes such as vascular malformations, systemic disease, vasculitis, portal hypertensive gastropathy, etc. Indications for endoscopic therapy. Endoscopic therapy should be only delivered to actively bleeding lesions, non-bleeding visible vessels, and sometimes to ulcers with an adherent clot, because the last two lesions possess very high risk of bleeding. On the other side, peptic ulcers with clean base or pigment spots and majority of non-ulcer non-varicose bleeding lesions, such as erosions, do not need endoscopy therapy. There are different methods for endoscopic therapy. The first, injection of fluids into the bleeding point, like adrenaline, sclerosants, or thrombin. The second choice is cautery, either with heater probe, laser, or argon plasma coagulation. And there is also a mechanical therapy or endoclipping. It has been recommended that use of adrenaline injections alone for peptic ulcer bleeding is not recommended. Always we need addition of second intervention as cautery or mechanical stopping bleeding following adrenaline injection because it reduces the further bleeding rate. What can we do when bleeding doesn't stop by endoscopic therapy? We can repeat endoscopy and endotherapy within 24 hours when initial endoscopic treatment was considered suboptimal. However, when bleeding is severe, other modalities can be taken in mind as angiography with embolization or even surgery. Optimal pharmacologic therapy after endoscopy includes high-dose intravenous proton pump inhibitors, which can be used as bolus first and after that as continuing infusion in patients with major bleedings. However, there is insufficient evidence to recommend the use of somatostatin or its synthetic analogs or tranexamic acid in non-varicose upper GI bleeding. It is better to stop taking medicines that are known to increase the risk of upper GI bleeding, such as steroids or non-steroid anti-inflammatory drugs. If we recognize the cause for bleeding, then causal therapy is recommended, such as H. pylori infection eradication or treatment of gastroesophageal reflux disease.